what we should do and how we can apply this to our patients.
Thank you for having me, Anna. Yeah, so I'm here to talk about a study that we recently published looking at breast cancer screening, specifically in women with ATM-CHEK2 and PALB2 pathogenic variants, which is a population that we're definitely seeing a lot on the breast imaging side come across our MRI screening queue. The paper was published in just last month, I think, in JAMA Oncology, and I'm happy to present kind of the rationale for the paper and how we did the analysis on behalf of my many collaborators. So I'll kind of be speaking on behalf of a consortium called CISNET that I work closely with, which is a consortium that performs modeling analysis to examine screening policy questions, and I'll go into a little bit more detail about how that works during the talk. So I just kind of briefly, actually, I'll start, let me back up just a little bit about kind of how this project came to be. Kind of the brainchild of the project is Mark Robson, who's a medical oncologist he's the chief of breast oncology at Memorial Sloan Kettering. And this was a topic that was of great interest to him. And he had a grant, and he really wanted to figure out a way to get more data to support how we approach screening in women with these kind of moderate risk pathogenic variants. And so he approached our consortium about collaborating to do an analysis, and it kind of ballooned from there. I'm sure everyone here probably already knows about ATM-CHEK2 and PALB2 because they're so common, but they kind of fall within this umbrella of moderate risk pathogenic variants in breast cancer susceptibility genes. So they are more common in the general population than BRCA1 and BRCA2, but they are lower risk compared to BRCA1 and BRCA2 carriers. They still collectively make up not an insignificant proportion of breast cancers, about 2 to 3% of all breast cancer cases. One of these pathogenic variants is identified. And so they vary a little bit across the different variants in terms of their projected lifetime risk. It varies from study to study depending on what you look at. In general, based on a review in 2015 across a bunch of different studies, ATM and CHEK2 were thought to roughly have a lifetime risk of about 25 to 30%. PALB2 a little bit higher, where we've seen estimates of closer to 40, 45% lifetime risk. And so current guidelines, in general, they're obviously at elevated risk. And so most societies recommend both mammography and supplemental MRI screening for these women. Most societies don't actually specify the age at which to start, unlike BRCA1 and BRCA2, where we actually have pretty clear consensus across different guidelines committees that start at age 25 for the MRI and start at age 30 for the mammo. The NCCN actually does specify different ages to start for each of these mutations, and they recommend starting at 40 for women with ATM and CHEK2 variants, and starting at age 30 and women with PALB2 variants. But Mark approached us about this because he said, it's an area of limited data, and that we have these guidelines, but they're largely kind of based on expert opinion, just from looking at the breast cancer incidence data. And so he wondered if there's a way to get a little bit better data to inform.
I can do that, but I just want you to know I have a lot more I can do.
But as you can imagine, there are no large trials for ATM-CHEK2 and PALB2, and so the impact of these different strategies. Okay, so what are our options if we're going to estimate the impact of a cancer screening program in different cancer screening guidelines? How do we measure what that program's impact is? So there's different methodologies. Ideally, we would have a randomized control trial with a mortality endpoint, which would be the gold standard. That would provide the most robust evidence for the effect of the screening program, and there's high quality control. But unfortunately, because they're time and resource intensive, they're often not feasible or just unlikely to be performed. And even when they are performed, they're often, it's idealized conditions. So it's not necessarily representative of what happens in the general population. Also, because especially in the screening setting where cancer is a rare event, they require really large samples. And unfortunately, the number of different cancer screening programs you can test is pretty limited. Then there's observational trials, the advantage of which is, of course, it's real world data. It's typically less expensive to collect, although not inexpensive to collect. But the problem with observational trials of screening is that they're prone to epidemiologic biases, including lag time bias, length time bias, selection bias, among others. And they also, like randomized trials, require lengthy follow-up if you're going to look at mortality as an endpoint. Then there's statistical modeling, which is inexpensive and is flexible. And is like, so if you could develop a logistic regression model, for example, where you try to synthesize effects of different factors and synthesize them into a single model. But these types of models aren't well suited to examining the effect of cancer screening because the relationships between different factors tend to be very complex. They also tend to change over time, and there are a lot of factors that are unobservable. So in general, we don't see a lot of logistic regression models trying to estimate the impact of cancer screening. So the alternative method that we used for this analysis is simulation modeling. Simulation models are a little bit more of an unusual method, but they lend themselves well to questions about cancer screening because they can integrate data from a lot of different sources, and they can handle really complex relationships and the dynamic nature of data. So for example, in the simulation model, which is essentially like a computer program, you can account for varying risk of cancer in a population, competing mortality risks. You can integrate another source of data for your cancer screening performance, as well as treatment efficacy. You can, and also cancer mortality and quality of life effects. And you can put all this stuff together and run your simulations, and you can output the metrics that are of interest to you, which might include cancer mortality, life expectancy, as well as quality of life metrics. So I'm going to kind of give like a very oversimplified schematic of what this actually is like, just because this was helpful for me when I first started learning how to do decision modeling. The idea is it's a computer program and it's simulating life histories of individual people one at a time. And these are hypothetical people, and each person that's run in the model has specific characteristics set at the beginning. And by running millions of people, you can mimic a specific population. And so the people in your model, they might have different birth years, they might have different levels of underlying breast cancer risk, they might have other breast cancer risk factors such as breast density. And then over time, they progress through different health states. So they probably start off in a healthy state, but as time increments in the model, they face risk of different cancer events, which they may or may not experience. So for example, the woman may develop breast cancer, and that risk can vary over time and can be a complex function dependent on her current age, what year she was born, as well as the presence of any risk factors. Once cancer is developed, it may or may not be detected. And whether it's detected might depend on how long the tumor's been there, how big it is, how fast it's progressing, whether or not screening is being performed, and if so, how good the screen is, as well as other mitigating factors like breast density, which might impact the probability of detection. Once detected and diagnosed and presumably treated, the patient then may face the risk of dying of cancer, which is going to be dependent on what the stage of the cancer was when it was detected, the subtype, the patient's age, and how well the treatment works that she received. And all along the way, there's always risk of competing mortality, which updates over time as the patient ages in the model. So you take these individual life histories and then you track all the events that happen and you put it all together and you aggregate it and you get a population level data set where you can pool together an enormous amount of data, including age-specific breast cancer incidence, breast cancer mortality, cancer stage distribution, life expectancy, as well as any screening outcomes that might be of interest to you, such as the number of tests that you do, how many false positives were a result in, and how many benign biopsies were performed. But the real advantage of these models is their versatility, in that you can run the model as many times as you want, and each time you can tweak it to represent a different screening scenario. So if you want to change the age that you start screening, if you want to change the interval, that's really easy to do, and you can just rerun the model. You can also just change the screening performance or change the treatment, really anything that you want to reflect the scenario that is of interest to you. And then you can compare your outcomes for each strategy. So essentially what you have is a virtual randomized control trial of a bunch of different possible screening programs. And then the challenge with this is, because it produces a lot of data, you have to think about how to display it in a way that's meaningful. What we typically do is we will try to display the trade-offs of each screening program by plotting the benefit that's of primary interest against the harm of primary interest for screening. So we'll often use like lives saved might be a benefit that we are interested in, and false positive screens might be a harm that we want to weigh against the benefits of screening. And so what you can do is, for each strategy, you can plot on the chart the corresponding benefits and harms, and line them up next to each other and see how they compare. And what policymakers often do is they'll look at this curve, and they will choose their strategy based on when they think the curve is starting to flatten. So like in this example, even though strategy C has the greatest benefit in terms of lives saved, it results in considerably greater screening harms than strategy B. So it ends up, at that point, there's kind of this tipping point where the harms maybe outweigh the benefits of going from B to C. So it's very subjective, which makes it a little bit difficult sometimes to interpret these results. But in this case, a policymaker might say that looking at the strategy B looks best, and so that's what we'll go with. And so it's an unusual methodology, but it's actually played a pretty big role in a lot of cancer screening policy decision-making over the years. And to address one issue of modeling, which is, it's a little bit hard to review, it's a little bit of a black box. The NCI started in 1999, started funding a consortium of cancer modeling teams with independent investigators across the country and across the world who specialize in modeling specific cancer screening programs. And so there's a breast working group of CISNET, which has worked collaboratively together since 1999 to specifically model cancer screening policy decisions related to breast cancer screening. And they have collaborated with the U.S. Preventive Services Task Force, as well as the American Cancer Society over the years. And so here are just the 6 institutions that are members of CISNET. So they come from the Dana-Farber Erasmus Medical Center. There's a joint model from Georgetown University and Albert Einstein, MD Anderson, Stanford, and the University of Wisconsin and Harvard Medical School. And so they work collaboratively by sharing some data and some common parameters, but each group works independently and has developed their own model completely separate from each other. They use different model structures and model assumptions. And the idea is that when you have multiple groups modeling the same problem, you can compare the results and see if there's agreement. And if there's agreement, then that strengthens the credibility of the results. And it also provides a range of plausible results given a range of assumptions. So that was kind of a long detour, but I wanted to kind of explain the methods because I thought that was important for kind of understanding the paper. But to circle back to the original question and the study, the purpose of this analysis was to use 2 CISNET breast cancer simulation models to evaluate different breast cancer screening options in women with ATM, CHEK2, and PALB2 variants. So for this particular analysis, there were 2 models. One was a model from Erasmus Medical Center in Rotterdam in the Netherlands, and the other model is the Wisconsin-Harvard model, which has investigators from both the University of Wisconsin and Harvard Medical School. As I mentioned before, the models integrate lots of different information from different sources, and then they both will run their own simulations to try to project cancer mortality, life expectancy, screens, false positives, and biopsies. So for this analysis, we came up with, well, we tried to come up with a simple set of strategies to compare. And so the way we approached it was we thought, okay, well, let's say annual mammography at age 40 is the minimum you would screen these women because they are high risk. So let's start with that. And then let's add MRI. And so let's start with adding MRI at age 40, which is when you start the mammogram. Then what happens if we start the MRI earlier? What if we started at 35 or 30 or age 25? And then kind of separately, we said, okay, well, then what happens if you start both the MRI and the mammogram earlier? So what if we start the MRI at age 30 and then we start mammogram at age 30? Or what if we start the MRI at age 30 and start the mammogram at age 35? So we looked at these different combinations of options for screening. And for all these scenarios, we assumed that screening was continued until age 74. Because beyond age 74, we don't have a lot of data to inform our models about the impact of screening. In terms of breast cancer risk, kind of in parallel, we wanted to make sure we were incorporating population-based estimates of breast cancer in women with these pathogenic variants. And the Carriers Consortium was working on a large analysis at the time, looking at this very question, at the population-based risk of breast cancer and some of these pathogenic variants. So we reached out to them. They published their results in the New England Journal in 2021, but they had not yet published them at the time we were working on this. And so we reached out to them and they were willing to work directly with us and share their data with us so we could incorporate it into the model, which was great. So the data that they provided for us for this analysis came from over 32,000 cases and 32,000 controls from 12 different population-based studies across their consortium. And importantly, these studies were studies that were not enriched for family history or early age of diagnosis, which we thought would help with making their risk estimates more representative of the general population. So here's kind of a selection of data they provided for us. So so these are the odds ratios of breast cancer from their analysis on the right for each of the 3 variants. They actually provided us with age-specific odds ratios, which we incorporated into the model, but just for simplicity, because it's a really long table, I'm just showing the overall odds ratios here. But you can see kind of consistent with prior literature, PALB2 had the highest risk, followed by CHEK2 and ATM. We also asked them for this prevalence of the different subtypes of breast cancer for each of these variants. And again, that was kind of consistent with the previous literature had shown, with ATM and CHEK2 having a strong representation of ER-positive breast cancers, whereas there's a greater proportion of ER-negative, HER2-negative cancers in the PALB2 cohort. Other parameters that were new to us for this analysis that we incorporated for screening for both mammography and MRI, we looked at a paper from the Ontario Breast Cancer Screening Program, which was published in JNCI in 2020, because it was just a really high quality paper that published the data comparing mammography to MRI in high-risk women over multiple rounds of screening. And then we assumed that women's treatment that they received was specific to their age, stage, and subtype according to NCCN guidelines. And we assumed that the treatment efficacy was equivalent to that reported in the analyses of randomized patients. So here are our results. So when we ran the simulations, first we looked at, when we incorporate this data from carriers, what is the lifetime risk of breast cancer diagnosis and death in the absence of screening across each of these variants. And again, the risk varied by variant, with PALB2 having the highest risk. These numbers here, the number is the average between the 2 models, and the range is the range across the 2 individual models. So the models actually have pretty close agreement with each other. Again, PALB2 is the highest risk, and breast cancer death range from about 3.4 to 7.7% in the absence of screening. So then when screening was applied, we found that mammography alone did have a significant impact on breast cancer mortality. So this is mammography starting at age 40, as shown by the gold bars here, and it reduced breast cancer mortality by 36 to 39%, which is pretty substantial. But we found that adding MRI on top of mammography actually really increased the mortality benefit of screening. So across all these other strategies here, which include adding MRI at different ages, the mortality reduction exceeded 50% for all three variants. And then we looked also at life expectancy gains. So like, are women also living longer? And we found that they were, and that adding MRI also increased life expectancy beyond mammography alone in each of these three variants. We saw that the life expectancy gains were the largest for women with PALB2 variants, which is expected both in part because the incidence was higher, and also because the tumors that they developed were more aggressive. So both of those contributed to greater life expectancy gains in this specific cohort. So then we looked at false positive screens, false positive mammograms and false positive MRIs, and compared that to life years gained. So we kind of specified at the beginning that those would be the two outcomes that were our primary interest, and we would see how those relate to each other in our model output. So this is the figure from the paper. The graphs are actually very similar for ATM, CHEK2, and PALB2, so I'm only showing CHEK2 here in the interest of saving space on the slide. But so here we've plotted false positive screens on the x-axis and life years gained on the y-axis. This point here is the strategy with annual mammography alone. As you add MRI, you can see that life expectancy increases, false positives also increase. And when we looked, we saw that, so the most effective strategy was starting MRI at age 25, as you'd expect, because the earlier you start MRI, the larger benefits you're going to see. But it wasn't particularly efficient. You know, once you compare starting at 25 compared to starting at 30, the difference in benefit was pretty small, but you're increasing your false positives by quite a bit. So we didn't think that was an ideal strategy. We went back and forth between whether starting MRI at 30 or 35 was preferable, because you can see when you start at 35, if you move it to age 30, you do get some benefit. You also are increasing your false positives. We thought these two strategies it was a little bit subjective, which one was better than the other. We also got some feedback from a reviewer that was a little bit subjective to choose one or the other. So ultimately we concluded that kind of starting in the 30 to 35 range was probably appropriate, and preferable to starting at age 40 or to starting at age 25. And you can kind of see in this chart here, these are the number of screens and biopsies per life year gained across the different variants. And you can see that you have kind of these incremental bumps and false positive screens per life year gained as you start MRI earlier, but then there's this large increase if you move from 30 to 25, which to us supported the fact that starting at 25 was probably too early. So then as a secondary analysis, we were interested in what happens if you also start the mammogram earlier. And what we found was interesting. We found that if you are screening these women with MRI and then you add a mammogram on top of that, in women under the age of 40, we didn't see much change in mortality, but we did continue to see an increase in false positive mammograms or false positive screens, as well as the number of benign biopsies. So just to kind of put this into context, if you start the MRI at age 30, that results in a 55 to 60% mortality reduction. If you then start the mammogram at age 35 instead of age 40, you're only changing mortality by about 0.1, 0.2%, maybe 0.3% if you start at age 30, but you're increasing the number of false positive screens by 300 to 600 per 1,000 women, and a considerable number of additional biopsies as well. So this was kind of an interesting finding that we thought was kind of food for thought, because in clinical practice in high-risk women, we usually do perform both the mammogram and the MRI at earlier ages. But at least according to the model, it's suggested that doesn't likely have much benefit, but maybe does increase the screening harms. So based on this, we concluded that women with pathogenic variants in ATM check 2 or PALB2, that breast cancer screening with MRI should be started at age 30 to 35 and adding mammography at age 40. And so there are a lot of kind of discussion points, I think, around our model findings. So one is that we were, I guess we were a little surprised at the magnitude of the benefit of MRI in this particular cohort, since they're not like a high risk cohort, like a BRCA1 population. But we actually found that our estimates, at least for relative breast cancer mortality reduction, were similar to prior modeling studies that have been done looking at screening in BRCA1 and BRCA2 carriers, as well as women with a history of chest radiation therapy. But keep in mind, these are relative reductions in mortality, and as we know from the life expectancy data and in this paper, the actual life expectancy changes are likely larger for the higher risk women. But in terms of mortality reduction, it exceeded 50%. The start age of mammography is kind of interesting food for thought for us. That we just kind of wanted to put out there and let the community discuss whether or not that might be something to consider. Based on our results, it seems that the benefit of mammography in women under the age of 40, if they're getting MRI, is maybe a little bit uncertain, and maybe it increases false positives and biopsies. Another thing that some of our colleagues noted was that we weren't even accounting for the possibility or theoretical possibility of radiation-induced cancers or performing mammograms in women with at young ages who have these genetic variants, although we don't actually know exactly what the magnitude of that risk is. And another thing is, the idea of staggering MRI start age and mammography start age is not totally new, because we already do that with BRCA carriers. It's a much younger age that we start the MRI, but we start in BRCA1 and BRCA2 carriers, we start MRI at age 25 and start mammography at age 30. So there is some precedent to staggering the two tests. So this just suggests that perhaps delaying that even more might be appropriate for these moderate risk women. And so the strengths and limitations of this analysis. So we were happy that the two models had really strong agreement. So even though these two models were completely separate models, they're well-established CISNET models, but they do completely different teams of investigators, and yet the results that we found were almost to the decimal point between the two models. So we felt pretty good about the agreement across the two models. Also, the fact that we were able to obtain the population-based breast cancer risk estimates, the most up-to-date risk estimates that we could find, thanks to the Carriers Consortium. But there were a lot of questions that we weren't able to look at because it was just too much for a single analysis. So we know that women with these variants, the risk of breast cancer, we're providing kind of overall population-based risks for this, but in truth, the risk likely is going to vary depending on what that woman's individual family history is. So of course, if you're counseling an individual patient, you're going to want to take that into account. When to stop continues to be kind of an unanswered question for lots of different screening populations, and this one is no different. We stopped our analysis. We typically stop our analyses at age 74, and that's just because the data gets so sparse beyond age 74 that we don't often feel comfortable making projections of the impact of screening beyond that age. And overdiagnosis, we did not consider in this analysis. In a lot of our analyses we do, when we look at mammography screening, we found that the estimates of overdiagnosis tend to be all over the map across the 6 different CISNET models. And so we never really feel great about reporting it when our estimates are so inconsistent. And it felt, we're in even more uncharted territory looking at overdiagnosis in the setting of MRI. I think we like to think that MRI is detecting tumors that have blood flow, because it's contrast enhanced modality. And so therefore it's more likely to be detecting biologically significant cancers compared to mammography. And so conceivably overdiagnosis should be less of an issue with MRI screening compared to mammography screening. But at the same time, we don't actually know that for sure. And so that kind of remains an unanswered question. And then I just wanted to acknowledge that this was all funded by a couple grants from the National Cancer Institute, as well as a grant from the Breast Cancer Research Foundation. I do want to acknowledge there were many people who worked together very hard on this. So again, it was led by Mark Robson from Memorial Sloan Kettering Cancer Center, the carriers, investigators led by Fergus Couch at Mayo Clinic, our Breast Cancer Surveillance Consortium collaborators, as well as the different CISNET modelers and consultants. And that's actually all I have. I went a little bit fast, but I'm happy to take any questions or have any discussion about the analysis or about the bigger topic.
Katie, this was such an amazing presentation. Thank you.
Rachel.
Oh, and I see Ben has his hand raised. I'm kind of curious about, well, I have so many questions, but I'll ask one, is just thinking about sort of how you assess the benefit or the sort of detection parameters for MRI and mammogram, and if that varies over time. Like, I'll say that in a clinical context that comes up is sometimes we'll identify these women at age 67 and they've been getting mammograms all along and they have super fatty breasts, and I'm sort of like, do I add MRI to this person? Am I really going to do anything? Am I improving their cancer detection or their overall survival? And so those were a few questions I have. And then I'm also, I mean, as a provider in VOCP, these data are fairly convincing, but they are in contrast with what the NCCN guidelines recommend. And so I guess I'm just curious as to your conversations and whether this has been presented to the NCCN group and those pieces.
Yeah. Yeah. Thank you, Rachel. Yeah, the question about the change in performance of screening over time is a really good one. And one of the challenges that we have when we're using these models is, we have to take the performance data that's available, and sometimes we have to make, there's only so many ways we can slice and dice it and still maintain like nice clean data. So what we did for the initial analysis was we did not vary it by age, we did vary it by screening round. So the Ontario program in their paper, they actually distinguish between early rounds of screening versus later rounds of screening, with things like specificity improving over time, and sensitivity improves over time as well. Same with mammography. We know sensitivity mammography improves over time, both age and number of screening rounds that you've had. So for the initial analysis, we accounted for a number of screening rounds, but not age. The reviewers came back to us and then said, well, you need to adjust for age, which was a fair point. It was just we didn't have that data in the paper we were using. So then for a sensitivity analysis in the paper, we did another analysis where we used age-adjusted screening performance using data from the Breast Cancer Surveillance Consortium. And ultimately the results were the same, because even though it does improve with age, it's like there's small improvements. And really what was driving the results for this analysis was the difference in sensitivity between mammography and MRI is so large that little changes in performance for each one over time kind of get swamped by that. That being said, your other question about, what is once a person is 69 years old and they've been screening, and so that gets back to the issue of when do you stop? And that's something that we didn't really look at, and it would be interesting to explore in another analysis. Yeah, I think that same question comes up for screening in all types of settings. Like at what point is it enough with MRI?
It's not so much about stopping screening, like I was saying, like 67, and it's more about like do you add MRI? Like how much does MRI add for a CHEK2 mutation carrier at age 67? Because I suspect that it seems to me that MRI adds more benefit when you are younger and the tissue is more difficult to assess, but I don't know if that's actually true, and maybe you could speak to that. But
I mean, I think that, yeah, we didn't break the data down in that way here, but I think you would expect that to be true because the sensitivity of mammography increases with age. You'd expect the difference in performance to be to get smaller over time. But yeah, we didn't actually account for that in this analysis. And then the other question about the guidelines, I mean, you know, it's tough because models, I try to think of models as like, it's a piece of information, right? Like I think it's a tough sell to any guidelines committee to make decisions purely based on modeling. And I think, you know, most guidelines committees wouldn't do that because still at the end of the day, they're not real people, they're hypothetical people. It's just a way of integrating a lot of different data. What's tough is sometimes, you know, in a case like this where there really isn't anything else. Other than, I think, you know, that just kind of judgment from people who are experts in looking at incidence and looking at, you know, these genetic studies. So, I think one thing is what we're proposing is slightly more aggressive in terms of we're proposing moving screening a little bit earlier for the ATM and the CHEK2 variants. And I imagine it's a tougher sell. But although I hope people will consider thinking about the implications of mammography in these young ages, and maybe that's something that a clinical study could be helpful for confirming. But I haven't, to my knowledge, I have not spoken directly with NCCN. I don't know if Mark has. I should check in with him and see if he's gotten any questions from the NCCN Guidelines Committee specifically.
And Barb Norquist is the person who would be our contact for the NCCN guideline. She's the one for the high risk committee.
Oh, okay. Oh. Ben, I see your hand up.
I have a comment, a question, and a request.
Okay.
My comment is that was a great talk. You did really what I thought it was super, and the way you explained the modeling was very well done, and it was totally worth the diversion to see how you explained it very well, and then how SysNet works, the comparison of the different groups. I just want to compliment you on that. My question is this: when you're doing the modeling, you're taking existing observational data and applying it in the model to say, if I do this intervention, then this is the benefit I'm going to see. So you have to have core data that you're using. One of the challenges, and you started to reference this, was you're making projections into imaging in the 30s and possibly 20s, and also projections about treatment outcomes in the same age groups when I'm actually particularly wondering about the mortality benefit data and how clear is that, and how much of that might be projected from older patients with the same. I'm sure you're adjusting for the tumor types, the triple negatives versus the luminals, but I wonder if the survival benefit, if it wasn't quite so good, would that change your how you would look at the data? Here's my request, and I just want to fit it in. Yeah. You had a really important slide where this is globally important, and where you said we really don't know much about the benefit of mammography under the age of 40. And that's because we really don't have large databases, but our data indicates it gets that line crosses and this is really important because what ministries of health do is they go, well, our population's younger, and I hear our average age of diagnosis is 42. So therefore, we will start our mammographic screening earlier. And that's a really flawed, non-evidence-based concept. So I actually think you're reinforcing the idea of we don't think there's a reason to be thinking mammography gets a whole bunch better with the data that we've got. But my question about the mortality, would that change if the survival benefit was being over-inferred about what happens in the 30s, would that change anything about how you would done that. Once again, great talk. Thank you.
Thank you. Yeah, I appreciate all those comments. So I'll try to answer the question about treatment. So the way treatment is handled in the model, and I should add that I am definitely not the treatment expert in our working group. It's Allison Curian from Stanford. She's the medical oncology consultant with our group who kind of oversees our selection of assumptions related to treatment. And I know that we use hazard ratios that have been estimated from meta-analyses of randomized controlled trials that are, they are specific to age at diagnosis, stage at diagnosis, and subtype, I believe. So I think they've tried, to the best that the data are available, they've tried to make adjustments by age, although I'm not actually sure how granular those adjustments are. But I think a bigger issue, one that actually comes up a lot in our discussions about our models, is we assume idealized conditions for treatment. So we take data from randomized controlled trials. We know that, of course, in the real world, not everyone gets that level of care for their breast cancer. We also know from running our models that the more effective the treatment, the more optimistic we are about the effects of treatment in our models, the less screening, the less benefit we see with screening. And when we start to downplay when we adjust treatment to make it less effective in the model, screening becomes more important. So that actually is an important assumption that we've been circling around a lot recently, thinking about like, what is the most, do we assume a person has access to standard of care, or do we assume that they may or may not, and use more real world assumptions? And for this, we assumed idealized treatment scenarios. So that was the treatment. I'm trying to, and then in terms of mammography in women under age 40, yeah, I agree. I wanted to be really clear in the paper to drive home that we're talking about women who are getting MRI. There's not much benefit to getting the mammogram. Unfortunately, we know MRI is not that easy to obtain in a lot of cases for a lot of women. It's not equally accessible to all women, depending on their insurance and financial status and a number of other things. And so, I just didn't want that message to get lost in the paper that women, if you can't get MRI, you don't get screening at all. But certainly if you're getting the MRI, that seems to detect the vast majority of cancers. When I did a literature review when writing this up, there are a few studies in the radiology literature that have looked at detection under the age of 40, and it is very rare for a woman getting a mammogram to have a false negative on the MRI and a cancer caught on the mammogram. That becomes more common in women over the age of 40, but under the age of 40, it's quite uncommon. So I think it fits, again, the data are sparse, but it is consistent with when you look at the radiology literature, what most studies have found. But again, the access to MRIs is the important piece. I forget if there's something else I didn't answer, Ben. Was that it?
No, you covered everything. That was great. And I thought your answers were very helpful. Thank you.
Yeah, sure. Savannah, I see your hand up.
Yeah, thanks. I agree with everyone. This was really great, and you did a very nice job of presenting this complex modeling that you guys do. The question that came to my mind is this: aside from varying the start date or age of screening, did you guys look at, or do you have plans to look at the frequency of screening? Like in particular for MRI, there are thoughts that every 2 or 3 years might suffice to derive the benefits. And anyway,
that's a really interesting question. We didn't for this analysis. We went back and forth about when we chose the strategies we were going to consider. We wanted this to be, and Mark wanted this to be like a really clinically relevant paper where we were going to look at strategies that we thought guidelines committees would be would realistically consider. And we thought if we start looking at MRI every 2 years, every 3 years, we might be deviating enough from the standard of care that they might not best-case strategies that guidelines would realistically adopt or would consider to be on the table. That being said, that is something we're interested in, and we are looking at those questions in other analyses in other different screening populations, because yeah, I agree. I think yeah, like with MRI, with the sensitivity being so high, and I think Christian Kuhl, who's one of the most prominent MRI researchers, has shown that, you know, biennial or even triennial MRI screening can still be quite effective. So that's.
Would you be able to do that modeling with what you have now, or is that something where you would need more data, evidence-based data to do it?
We could do it. Yeah, no, we can definitely do it. It's, you know, the more we deviate from the real world data, the more it's, you know, it's a projection, and we're
right.
But we could definitely come up with some educated guesses of what the effects would be.
Yeah, because I know from the ECOG Akron world, when they did the abbreviated MRI, Chris Comstock and Christian Kuhl did the abbreviated MRI trial. The next phase of that they were planning was to do something called the PRISM trial, which was going to propose 3-year interval MRIs and compare to annual or something like that. Yeah. So maybe we could do a virtual PRISM instead or something with your modeling. It'd be pretty interesting to see how that performed. So thanks.
Yeah, no problem. Yeah, and I just, you know, another thing, one area where modeling can be helpful when you're starting to deviate from the data that are available, is we could do an analysis where we run it, or if we wanted to try to inform the clinical trial design, you know, we could run a bunch of different strategies and then be like, and then see like which look the most promising, and then a trial could be designed taking that into account, since the actual trial is going to have, you know, limited number of arms. So that's another application of modeling that's sometimes used. Yeah. Thanks. Yeah, thanks. Ellen, I see your hand up too.
Yeah, thanks, Katie. That was a great talk. So, you know, you're looking at starting MRI screening earlier, and you know, these patients, especially say the CHEK2 mutation patients, we don't, you know, routinely recommend, say, prophylactic mastectomy. So you're kind of committing them. I mean, as it is, we start at 40, so it's not like it's that much earlier, but you're kind of committing them to, you know, 40 plus years of yearly MRI screening. And then this is where, you know, it's great that, you know, there are strategies being looked at decreasing the number of lifetime MRIs that these patients get. But, you know, do you, what are your thoughts on the concerns of the IV gadolinium? Yeah, can you speak to that? Because sometimes I'm not sure how to counsel patients, because you know, you want them to get the MRIs, but then sometimes you feel like, oh, it should be full disclosure, you know.
Right. Yeah. No, I completely hear you. Yeah, so you're right. So when we're starting the MRI at young ages, you know, if you start at age 30 and you continue until you're in your 60s or 70s, that adds up to a lot of screening MRIs. And there were some studies, you know, over the past few years that have shown that with some of the older gadolinium agents, there appeared to be some changes in signal in different parts of the brain that was had a dose-dependent relationship with the amount of gadolinium received. And so I think that definitely has given people some pause, but ultimately, there's still never been any studies to show any clinical correlation with those imaging findings. So based on what we know now, that seems to be only an imaging finding that doesn't have any clinical consequence. The other thing that's reassuring is that the agents that was seen with are older agents, and since then we've developed different types of gadolinium contrast agents where we don't see that deposition like we did with the older agents. But yeah, I mean, MRI, it's, you know, as enthusiastic as I am about the benefits that we saw in this paper, you know, it's not as easy of a test as mammogram, and that it's an injection, it's a longer exam, and so I know those are all things to be transparent about with patients when you're talking about the pros and cons of screening in early ages.
Thank you.
Yeah. I don't see any other hands up right now. Anna, is there, or Ben, do you see anybody else?
Ellen's hand is still up. That's it.
Katie, I'll just make one more comment. Sorry, related to that last conversation, but
Oh, yeah.
as you know, we're working on non-contrast MRI for breast screening. And so we're in the works at developing a new ECOG Akron trial to really try and pin down what expected performance we can derive from that. We know it's probably going to be lower in sensitivity than contrast-based MRI, but it'd be good to talk with you further just to kind of make sure that we're building in the right considerations for that trial to allow for some of this modeling work to project how it might be useful in screening, applications later. So
Yes, yeah, I should have mentioned, yeah, Savannah is one of the world's experts in non-contrast MR screening techniques, which is
which we don't know how well works for screening yet, but we're
yes, but he's working on it. Yeah.
Well, please work as fast as you can.
We do have a trial open here at SCCA where we're enrolling patients now, and so we're collecting a few hundred screening, studies currently. And so over the next year, we should finish up our recruitment and be able to evaluate that, at least in a reader study scenario for performance. That's it. Thanks.
Katie, I do have one more question,
Yeah.
and which is you mentioned Christian Kuhl, and she does this rapid MRI thing that everyone talks about. I don't have a good sense of where rapid MRI fits in comparison to what we would consider standard MRI versus these other techniques. What is your opinion about where this rapid MRI fits?
Yeah, that's a good question. So over the last few years, what people like Savannah have shown in all of her MRI research is that we've learned that cancers actually enhance very early, and benign things tend to enhance late. And so when MRI was first developed for the breast, we had these very long protocols where we would inject contrast and scan over and over and over again and be looking like 5-10 minutes out from the contrast injection, trying to construct these complicated kinetic curves, looking at the pattern of blood flow in the breast to find cancers. And what we learned is that actually what matters is what enhances first, and the stuff that enhances later is less likely to be malignant. And so there's been a real push to shorten MRI scan time and to drop some of these late sequences. And there's a little bit of a continuum, like there's, we talk about abbreviated MRI is a different MRI, which is 5 to 10 minutes where you only do one post-contrast sequence. But really, I think what's happening across the country is that people are just shortening the regular MRIs. And so now the difference between a shortened standard MRI and an abbreviated MRI it's pretty blurred. And so, but in general, yeah, there is a push to get scan time down to within 10 minutes, say, because it's easier for the patient. It helps with throughput. And the data suggests that it performs as well, that there's no loss of sensitivity with that approach compared to the full protocol MRIs. So if you hear about abbreviated MRIs, it's not really a different technology. It's just scanning a little bit less. Savannah, is there anything?
Oh, no, I just was going to ask, along those lines, do you have anything to comment on about contrast enhanced mammography, which is yet another option that gives us a very similar, method of screening with vascular information?
Yeah. So contrast enhanced mammography is another kind of emerging modality, which is generally used in other sites in the country. It's primarily been used in the diagnostic setting, and more recently there have been trials looking at it in the screening setting. We actually just did a trial here that Janie Lee led, where we're doing a reader study comparing contrast enhanced mammography to MRI in some of our own patients. it's an appealing technology because it's faster, it's a little more comfortable than the MRI for most patients. It doesn't inject it doesn't require gadolinium. It is an injection of iodinated contrast, so it's the same contrast that's used in CT. But in general, you don't have the same issues with claustrophobia, and the exam is much shorter compared to the MRI. And there have been some studies of patient preferences, which have shown that most patients prefer the contrast-enhanced mammogram. We didn't look at that here because the data they're still pretty sparse for the use of contrast enhanced mammography in screening populations, but what is out there suggests that it's a pretty good alternative. So we may see over the next few years, as more trials are become available, we may see it incorporated into guidelines. There's at least one ECOG trial right now, CMIST, is that right, Savannah? Which is looking,
it's ACR, not ECOG-ACRIN.
Oh, it's ACR, okay.
And GE sponsored, I think, but.
That's right, which is looking at contrast enhanced mammo in women with is it women with a history of breast cancer, I believe.
That I don't know.
Yeah, Janie, if Janie's still on, she would know. But anyway, so that is on the horizon as maybe the next screening tool that might start to have mass appeal. We're just about at the top of the hour. I really appreciate all the questions and interest, and feel free to reach out if you have any other suggestions or ideas. I'd love to discuss them.
Thanks, Katie.
Awesome job.